Hey there, health enthusiasts. Welcome back to our channel. Today, we're diving into a topic called febrile seizures. Now, before we get started, make sure to hit that subscribe button and ring the notification bell so you never miss out on our valuable content. Let's jump right in. The International League Against Epilepsy, ILAE, defines febrile seizure as a seizure occurring in childhood after 1 month of age associated with a febrile illness not caused by an infection of the central nervous system, without previous neonatal seizures or a previous unprovoked seizure, and not meeting the criteria for other acute symptomatic seizures. That is, a seizure in a child without previous afebrile seizures, without significant prior neurological abnormality, and without signs of CNS infection or metabolic disturbance. This benign condition usually occurs between 6 months and 6 years of age. Occur in young children at a time in their development when the seizure threshold is low. This is a time when young children are susceptible to frequent childhood infections such as upper respiratory tract infection, otitis media, and viral syndrome, and they respond with comparably higher temperatures. Occur without previous afebrile seizures, no significant prior neurological abnormality, and no signs of CNS infection. Recurrence rate depends on the age of the child. The younger the child at the time of the initial seizure, the greater the risk of a further febrile seizure. When identifying the causes, febrile seizures are normally associated with simple viral infections such as human herpes simplex virus 6, influenza viruses, adenoviruses, and parainfluenza. There is evidence for a genetic basis. Febrile seizure susceptibility trait with an autosomal dominant pattern of inheritance with reduced penetrance has also been found. The risk factors for developing febrile seizures are: family history of febrile seizures, high temperature, identified developmental delay, perinatal illness requiring hospitalization, so neonatal discharge was after 28 days, daycare attendance. Presence of 2 of these risk factors increases the probability of a first febrile seizure to about 30%. Maternal alcohol intake and smoking during pregnancy. Risk factors for recurrent febrile seizures include: young age at the time of first febrile seizure, relatively low fever at the time of the first seizure, family history of a febrile seizure in a first-degree relative, brief duration between fever onset and initial seizure, multiple initial febrile seizures during the same episode. Risk factors for subsequent epilepsy later include complex febrile seizure, family history of epilepsy or neurologic abnormality, developmental delay, and febrile status epilepticus. When assessing febrile seizures, we can classify them according to the features they present. Simple febrile seizure consists of fever, generalized tonic-clonic seizure, duration of less than 15 minutes, and complete recovery within 1 hour, do not recur within 24 hours, and do not recur within the same febrile illness. Complex febrile seizure consists of fever, focal seizure features at onset or during the seizure, duration greater than 15 minutes, incomplete recovery within 1 hour, recur more than once in 24 hours, and recurrence within the same febrile illness. Complex febrile seizures may indicate a more serious disease process, such as meningitis, abscess, or encephalitis. Afebrile febrile seizure is where seizures occur in an acute infectious illness, particularly gastroenteritis, without documented fever. Features consistent with simple febrile seizure. Talking about evaluation. In a simple febrile seizure, once the seizure has terminated, the assessment should be aimed at determining the cause of the fever. A history with an examination of the cause duration of fever, e.g., viral illnesses, gastroenteritis, should be elucidated. Look for the following risk factors that make simple febrile seizure unlikely, such as 6 months of age, consider CNS infection, greater than 6 years of age, any features of a complex febrile seizure, signs of CNS infection, previous afebrile seizures, progressive neurological conditions, developmental delay or regression. Evaluations of the patient's neurologic status, meningeal signs, trauma, or any toxic ingestion. Recent antibiotic use is particularly important because partially treated meningitis must be considered. No investigations are indicated in a simple febrile seizure, where the focus of infection can be identified clinically and the child returns to baseline mental state. blood glucose, electrolytes, calcium, and venous gas can be done. Routine laboratory studies usually are not indicated for febrile seizures unless they are performed as part of a search for the source of a fever. Investigations for the source of fever, including lumbar puncture, should be guided by the nature of the presentation and age of the child. A lumbar puncture can be considered if suspecting meningitis. A European study showed children with febrile seizures have lower ferritin than those with fever alone, and iron deficiency, but not anemia, is associated with recurrence. There is no role for EEG in simple febrile seizures and a limited role in complex febrile seizures. In a prolonged or focal febrile seizure, consider CNS imaging after consultation with a senior doctor. A CT scan should be considered in patients with complex febrile seizures. These seizures are managed like every other seizure. Uncomplicated seizures usually resolve after a few minutes spontaneously. However, therapy should be administered if seizures are greater than or equal to 5 minutes or complex. Patients with active seizures should be treated with airway management, high-flow oxygen, supportive care, and anticonvulsants as necessary. Postictal should receive supportive care and antipyretics as appropriate. After a febrile seizure, initiate antipyretic therapy, NSAIDs, and acetaminophen. Long-term continuous or intermittent prophylaxis with anticonvulsant drugs, e.g., phenobarbital or diazepam, is not recommended. The following is the management flow chart from RCH Guidelines for active seizure. This same method is used for febrile seizures if necessary. Observation for 5 minutes is done while waiting for the seizure to stop spontaneously. No need to check oximetry or apply oxygen. If the seizure lasts more than 5 minutes, then start monitoring, provide oxygen, and give 4 benzodiazepines. Reassess in 5 minutes, still seizing, give another dose. If still seizing, go for second line of levetiracetam or phenytoin. Still seizing after 5 minutes, use the non-used second line drug. Finally, manage the airway and call senior staff as the last line of management. Post-seizure period as stated in RCH. Position the child in the recovery position, maintain the airway, and monitor for further seizure activity. Consider discharge when the child returns to normal neurological state following a simple febrile seizure, or serious bacterial infections excluded or adequately treated or underlying illness managed appropriately, or parents aware of first aid advice and management of possible subsequent seizures. When discharging, provide information on verbal and written advice about convulsion management and fever care, give parent information sheet. Follow up as required for the underlying illness. Offer a review appointment with a general pediatrician, especially if complex or recurrent febrile convulsions. Alright, folks, that wraps up our discussion on febrile seizures. If you found this information helpful, please share it with friends and family. Don't forget to like this video, subscribe to our channel, and hit the notification bell so you never miss out on our latest medical insights. Stay informed, stay safe, and take care of yourselves.